First of all, thank you, Carl, and the meeting organizers for inviting me to share some of our experiences using DERIVA ML. I apologize, I can't be there in person. We have our annual vision research meeting here in Denver, Colorado. But nevertheless, we are very happy to be a part of this effort. We really think DERIVA ML is ideal for the ophthalmology use case, and I'm going to share some of our experiences over the past 3 years. Before I begin, I'd just like to acknowledge some of my funding sources, including the National Eye Institute and various foundations. So full disclosure, I have never used FaceBase. But as you know, FaceBase is based on the DERIVA reusable data management platform. And we have repurposed this for the ophthalmology use case in a platform that we call IAI. And I'm going to just back up here all the way back to 2022 when Carl and I first started collaborating and thinking about how we can use DERIVA to address some of the issues that we're facing in ophthalmology. It was around that time where AI was really taking off. It was really entering the collective consciousness. This was when ChatGPT was released. This is when NVIDIA stock, if you had it, was really taking off. And we were also at the time, and still are, kind of grappling with the role of AI as a friend or a frenemy. At the same time, due to the AI boom, we were contemplating the best applications of AI in healthcare, and this applied across all specialties. And the implications of AI in healthcare are very clear. It has the potential to improve access to care, enhance the quality of care, optimize resource utilization, all of which are sorely needed across all specialties. So when we first started using DERIVA, it was based around the glaucoma use case. And since I am speaking to a slightly different audience, I'm going to give just a couple of background slides on what is glaucoma. So glaucoma is actually an optic neuropathy. It's a disease that affects the optic nerve, which connects the eye to the brain. And it is the most common cause of irreversible vision loss worldwide. It currently affects over 80 million people. 3.5% of people over the age of 40 has glaucoma. And one issue with glaucoma is that its progression is rather indolent, which has led to it being called the silent thief of sight. So here's a healthy visual field, and what you can see here is there's also a very healthy pink-looking optic nerve. The pattern of vision loss in glaucoma typically starts in the periphery, where patients are not aware, and this vision loss gradually spreads until it affects the central part of the vision. So most patients are not detected until they have significant structural damage to the optic nerve and severe vision loss. So this really becomes an issue of early detection because there are plenty of treatments that are available once patients are detected. And we've known for a while that AI was very promising in the field of glaucoma because we do a lot of diagnostic testing. This includes photographs of the optic nerves to look for structural damage, as well as other structural tests such as OCT and functional tests such as visual fields. So in a way, glaucoma was an ideal use case for DERIVA, and it was very well suited for AI analysis, although there's a caveat, which I will mention later on. And here's one of the earlier models. This was published in JAMA. This was a group out of Singapore that developed a convolutional neural network that could detect patients who appeared to be at high risk for glaucoma. And they demonstrated that the performance of this model was excellent. So we knew that if we had appropriate data and the appropriate computational infrastructure, that we could begin to develop these algorithms for glaucoma detection in the population. And of course, there's been a boom over the past decade or so in terms of the utilization of AI in glaucoma, but really what's been limiting is a robust computing platform with which we could centralize our data and develop these models and deploy them in a reproducible and transparent fashion. So here, I'd just like to provide some background. What is the need for AI implementation in glaucoma care and really eye care as a whole? And this really starts with the glaucoma care crisis, which is really an eye care crisis, which is that the prevalence of all eye diseases, including glaucoma, is rising worldwide due to aging of the world's population. Within the United States, the size of the ophthalmology workforce is actually declining due to physician burnout, early retirement, and this is creating a tremendous gap between the demand for eye care and the supply of ophthalmologists. And it's well known in the field of ophthalmology that barriers to access, delayed treatment contribute to vision loss, which ends up being costly both to the patient and the health system. So we also know that within ophthalmology, we're horribly inefficient with our resource utilization. We need tools to help standardize care. This was a collaboration that we had with Kaiser Permanente, which is a large managed care healthcare system here on the West Coast primarily, in which we looked at 300,000 young adults who had been referred for glaucoma evaluations. We found only 8% of them were diagnosed, and that's due to lack of standardization at the level of referral. And we also found that with simple risk stratification, we could identify that more than 50% of them had a risk less than 5%. So all of this data was suggesting that we needed some form of standardization for eye care, and especially to grant earlier access to eye care and to provide better care overall. We really thought that AI was the solution here. So the question became, how do we actually harness AI to advance glaucoma care in the real world practice setting? And here we needed a vehicle to deliver the care, and telemedicine was really perfect. So telemedicine is this idea of using available digital technologies to deliver care to patients where they live in a more readily accessible fashion. And ophthalmology has been ideal for this because we are able to obtain so much information about the eye just through simple fundus photographs, such as the one that you see here, that can be used to detect a wide range of common, potentially blinding eye diseases. And so this was when Carl and I first met to establish ATLAS, which is the AI and Teleophthalmology in Los Angeles initiative. This is a multidisciplinary effort, a collaboration between the USC Roski Eye Institute and ISI, as well as the Los Angeles County Department of Health Services and Lauren Daskovich. And our goals here are really to deliver eye care to underserved communities, improve the quality and equity of eye care, and to enhance efficiency and cost effectiveness. And we've known for a while that efficiently implemented teleophthalmology can have a tremendous benefit for public health. For a while, the access to retinal exams for diabetic retinopathy, which is a common blinding disease, was very poor until Lauren implemented this teleretinal screening program in 2013. And this program was highly effective. It screened over 21,000 patients over a 3-year period. It saved 14,000 in-office visits. It reduced the wait times by 90% and increased the rate of DR screening. And so we really wanted to leverage this infrastructure for glaucoma detection. The network is distributed over 17 sites across Los Angeles County, serving the underserved patient population. And over 2,000 patients are screened per month using fundus photography. So the question here is, how do we utilize this infrastructure, but then add rigorous analysis methods on top of it to detect at-risk patients? So already we were doing some degree of glaucoma screening for this diabetic population by looking at these fundus photographs. We had criteria for patients who should be referred and who shouldn't be referred. And we knew that this program was effective even when it was run manually. This was a retrospective study in which we looked at 817 successfully referred patients, and 2/3 of them were actually presenting for in-office care, which is quite remarkable in this patient population. And 1/4 of them were being diagnosed with glaucoma. Many of them did not know they had it. But when we looked at this workflow, we realized that there were several limitations that we needed to address. First of all, there were delays in the analysis of these images by optometrists. There was high variability among optometrists in looking at these images. And there was only a single risk category, so that even high-risk patients were getting stuck in long queues waiting for in-office evaluation. So we really thought that AI was the solution to all of this. So this is where we run into a key challenge when we're talking about ophthalmology glaucoma, and especially glaucoma data, which is that we have a very multimodal evaluation. Typically, to diagnose glaucoma, we're looking at functional and structural data. We look at the optic nerve. We evaluate clinical and demographic characteristics. So what we needed was a platform where we could integrate all of this disparate data in order to make our classification of glaucoma. And this is where there was a need for both a data and computing platform. And that is when Carl introduced us to DERIVA ML. This is our version of DERIVA ML, which we call IAI. And within this platform, we have well-curated and robust data sets specifically for the ophthalmology use case. This is a representative snapshot of what the interface looks like, where we have aggregated data on over 10,000 LA County patients at this point. And because all of this data is in one centralized location with an integrated compute platform, we've been able to work with this data. We've developed algorithms for the county to automate the detection of referable glaucoma. And we've demonstrated that this model performs just as well, if not better, than human experts. And we've also identified that human experts are highly variable in grading, which highlights the need for the implementation for these types of AI solutions for disease detection. We've brought in other data sets as well. So in collaboration with LA County, we had one data set of over 10,000 patients, but we've also integrated USC data, which is much more robust and multimodal in nature. And all of this data is harmonized to a common data model. And by doing this, we've been able to develop more sophisticated algorithms. And also within DERIVA ML, we've been able to bring in advanced foundation model architectures that we can apply to this curated standardized data. For example, here we developed a model that could detect patients not just who look suspicious for glaucoma, but who would actually have manifest glaucoma. And what you can see here is we were able to, within this platform, grade the data and have meaningful apples-to-apples comparisons of the model compared to humans with similar data input, which is a color fundus photograph, which you can see in red here. And at the same time, we had all of the modalities in one central location, which allowed us to look at the benefits of adding different modalities together in the diagnostic decision-making process, while also benchmarking against reference labels that were provided by glaucoma experts analyzing all of this integrated data. A big focus recently has been on reproducibility, and that's because when we are deploying AI in the real world, we need to know exactly how we developed the model and what inputs went into it. And so this has been a central focus over the past year in terms of having this reproducible framework. And we've incorporated the Hydra reproducibility framework into all of this, where we instead of writing new code every time, we focus more on configuration files that are easily trackable so that we know how each model is developed. And of course, you heard about the integration of the agentic AI, which has been Claude Pro, which we helped with the conversion process. And all of this is really to align our efforts with this emphasis placed on replication and reproducibility by the NIH. So what we have here now is a compute platform for ophthalmology data that really covers the entire life cycle from generation all the way to interpretation. And this has proven to be useful not just in glaucoma, but for other specialties or subspecialties within ophthalmology as well. So we've been able to integrate other data formats and data sources. And one I'd like to highlight is the integration of AI Ready. For those of you who are not aware, there was a common fund that supported the acquisition of 4 AI-ready datasets, including one within ophthalmology for diabetes called AI Ready. And recently, we've been working with this AI-ready dataset within the IAI platform, and this is work that has been supported by the AIM Ahead training program. But the goal here was really just to demonstrate that by having all of this multimodal data in one central location with the ML component on top of it, that we can begin to do very interesting analyses of the data, looking at embeddings, and really comparing between the different modalities to learn new things about what this multimodal data can tell us. So in summary, the demand for eye care is rapidly rising worldwide. AI provides a potential solution to meet this demand. And DERIVA ML enables the reproducible data science across ophthalmology and beyond that is really necessary to give clinicians and patients confidence that this technology is being deployed in a reproducible and transparent fashion. And we do believe that more prospective AI implementations are needed, again, to give people confidence in this technology. So I'd really like to acknowledge Carl. He's been really a driving force behind our advances in the field of ophthalmology. And I thank you very much for your attention today.